This morning, I am pleased to introduce Dr. Mojdehbakhsh. After attending NYU, she conducted research in cognitive neuroscience and then received a master's degree at Boston University. She then went on to medical school at Drexel University College of Medicine in Philadelphia and is now one of our administrative chief residents here. She is next going on to GYN Oncology Fellowship, also here at UW, yay. And her research interests include how telemedicine can improve access to healthcare, which she will enlighten us on this morning.
Thank you. Good morning. Thank you, everyone who's in the room and also virtual. Can everyone hear me okay with the microphone here? Hopefully online. Okay. So today I just want to touch on a couple areas where telemedicine is changing the way we deliver healthcare in the field of OBGYN. And this has really come from the boon of data that has been developed during the COVID-19 pandemic. I have no disclosures. So today we'll just very briefly review the outline of the status of telemedicine in OBGYN. We will assess why telecontraception is a safe and effective way at reducing barriers to obtaining contraception, and also look into how teleabortion is becoming more popular and a viable alternative to traditional in-person models of abortion care. So there are multiple terms and definitions that are used in the field of telemedicine, and different ways that we use to describe using technology to deliver healthcare. So these are just a couple terms. You'll come across many with many different definitions. But telemedicine can be just defined as the use of technology to deliver healthcare services and information at a distance in order to improve access, quality, and cost. These are often synchronous encounters. So these are the kind of encounters you have in your clinic, for example, when you schedule your telehealth or telemedicine patient visits and you're having an actual conversation via phone or video. And then another term is telehealth, and this a little more broadly can be defined as a service that allows consumers to access health education for support or self-management through the internet or via computers or wireless devices. And these are often asynchronous methods of delivery, also referred as store and forward in a lot of literature. So this is accessing a website or an app to get a prescription, which we'll kind of talk about more later. Both synchronous and asynchronous forms of healthcare delivery have been adopted in many subspecialties of OBGYN, and this has particularly increased during the COVID-19 pandemic. They've been changing the way we interface with patients. We have in many areas come to understand more about the barriers patients face when seeking healthcare through these methods and how providing healthcare through technology can actually relieve many of these. This topic is extremely vast and has many facets. So today I'll just be focusing, as I said, on asynchronous methods of delivering contraceptive and abortion care in the US. However, I will spend one slide on the topic of reimbursement, and this is kind of in regards to synchronous telemedicine specifically. So reimbursement has really changed since the start of the COVID-19 pandemic with the increase in these type of visits in hospital systems. Therefore, it might change again after the public health emergency status is lifted. Some states will have permanent policies to address telemedicine reimbursements since that's become such an integrated way that we deliver healthcare. There are differences between temporary and permanent policies, and the switchover will really depend on when each state ends their public health emergency status. So, for example, in Wisconsin, after the public health, let's see if I can have my mouse show up here. I may not be able to point, but you can see in this little chart, you have pre-public health emergency, during, and post. And during this COVID-19 pandemic, reimbursement has been available for both telephone and video encounters. However, post in Wisconsin, it will likely just be for video encounters, so that will be a change. but they haven't kind of determined what exactly that will look like yet. And there's a really informative website called powertodecide.org that really has like each state by state policy and like the current status of each public health emergency status. So we'll talk about telecontraception first, kind of where it has come from and the current state of this contraception delivery method. So telecontraception would be a asynchronous mode of delivery. Like I mentioned before, it's the provision of contraception through a website or smartphone app. So this is different than patients calling to clinic, having a video visit, asking for a prescription. This is not a new phenomenon, having this kind of remote way of providing contraceptives. In the US, an in-person model for prescribing and refilling contraception has been the convention, where patients make an appointment, have a consult visit, get their prescription, but are often asked to come back yearly for a refill. Reasons for this have been cited by healthcare professionals, include wanting to keep patients up to date on preventative screenings by having them come into the clinic, as well as the desire to evaluate patients for contraindications to hormonal contraception. However, for over a decade, the idea of over-the-counter contraception has been studied and is in fact available in many countries around the world. ACOG supports over-the-counter contraception without an age restriction. So this includes OCPs, the patch, vaginal rings, and Depo-Provera. A large driver for this stance is that inconsistent or non-use of contraception we know is a result of barriers to access to contraception. And ACOG also states in this committee opinion that pelvic exams, STI testing, and pap smears are not reasons to prohibit a patient from obtaining contraception. There are organizations, one of them is called Free the Pill, and these organizations provide accurate information about the safety of over-the-counter hormonal contraception and the current steps being taken to approve this in the US. The most recent development on over-the-counter contraception in the US is that the FDA has postponed an advisory committee meeting for the first application to move a progesterone-only pill to over-the-counter. So currently still no approved over-the-counter contraception. For perspective, this is a map about describing where over-the-counter contraception is available around the world, and that's the circle pattern. So a large portion of the world already has over-the-counter contraception available, with notably the US, Canada, Europe, Australia being exclusions. So there is much data exists to support a strong argument for over-the-counter contraception. The main qualms with this method revolve around screening for contraindications to combined hormonal methods. What we do know is that over-the-counter contraception has similar continuation rates to prescription. And with respect to safety, we know that progesterone-only options almost have no risk for VTE, which is a concern with combined methods. And we also do have to keep in mind that the VTE risk in pregnancy is much higher than combined oral contraception use. So the other kind of piece of this is that there is a lot of data to show that self-screening tools are effective at screening for contraindications. So not necessarily requiring a physician in person to ask these questions. So this kind of just depicts the VTE risk in different populations. So in general, the increase in VTE risk with combined methods is due to estrogen. So we know that ethinyl estradiol increases the production of liver proteins involved in the coagulation cascade. This results in a slightly different or higher procoagulant effect. The risk of this is more unclear with the use of patches and rings. So this is mainly with oral pills. In this graph here, we can see the rates of VTE comparing non-pregnant, non-combined oral contraceptive users to combined oral contraceptive users to pregnancy to postpartum. So obviously these first two bars are pretty small in comparison, which is important when we're counseling patients and also to keep in mind ourselves when we're counseling patients. These numbers, if they're a little small, so this is the number on the bar graph, there is number of women with a blood cut out of 10,000 women years. So why do we have to screen patients in person? Well, the answer is maybe we don't. We know that contraindications to hormonal contraception are mainly due to estrogen, as we previously discussed, and there are absolute and relative contraindications, as most of us know. So some of these kind of absolute contraindications include hypertension, migraines with aura, history of VTE, smoking, and age 35 years or older. And other kind of more relative contraindications may include controlled hypertension, being fewer than 20 days postpartum and not breastfeeding, breastfeeding 6 weeks or fewer to more than 6 months postpartum, and migraines without aura. These are all things that we can ask people over the phone as well as we can ask them in person. One study called the Contraceptive Choice Project found that 6.9% of the 1,010 person sample self-reported a contraindication. However, upon chart review of these patients, it was found that actually only 2.4% had an actual contraindication to combined methods. So this and other studies tell us that patients tend to overestimate contraindications and that true contraindication rates are quite low. This is an example of a questionnaire that covers all the absolute and relative contraindications or information that we would want to know based on the U.S. medical eligibility criteria for contraceptive use. So a questionnaire like this is pretty short. It's easy for a patient to complete in any form, whether it's in person or online. What about blood pressure checks? Since hypertension is a contraindication to combine oral contraceptives, how are we going to know that a blood pressure is appropriate if we're not seeing them in the clinic? According to the U.S. Selected practice recommendations for contraceptive use, they do recommend a blood pressure before providing combined oral contraceptives. However, this can be taken at a provider office visit. It could also be from the pharmacy. It could also be from home. So patients could report, for example, a blood pressure they got at their PCP 5 months ago, and that would be sufficient. Interestingly, there is an intermediate option between prescription only and over-the-counter contraception that does exist in some places in the US. This is called pharmacy access. Patients essentially can get a prescription for contraceptives from a pharmacist after having a consult, obviously going through all the contraindications and medical history, and then getting the prescription directly from the pharmacy. This is a map showing in which states this is actually available, and that's depicted by the dark pink color. The light pink color represents states that has had pharmacy access legislation that has expired. So why do we care so much about changing the way contraception is provided in the US? This is driven by the fact that we know a large portion of our population reports barriers to obtaining it. This not being able to obtain contraception obviously is the most important risk factor in unintended pregnancies and the associated morbidity of these. For example, we know that 82% of pregnancies among women aged 15 to 19 are unintended, and lack of access to contraceptives is the main reason for non-use in this population. A national survey of women at risk of unintended pregnancy showed that 68% tried to get prescription contraception. 29 of these patients had trouble getting prescription and or refills. Many of the women who cited having trouble getting prescription or refills were uninsured Spanish or Spanish-speaking women. Some of the barriers that were reported in this study included cost or lack of insurance, difficulty making an appointment in a timely manner, the provider requiring an in-person clinic visit, or not having a doctor at all. So all of these things are barriers that prevent people from obtaining contraception that can then lead to unintended pregnancy. I'm sure most of us are not surprised to hear about these barriers, as they are similar in many medical contexts that we encounter. Other populations that were at higher risk of not getting contraception are women under the age of 35, women with less than a high school degree, unmarried cohabitating women, women whose incomes were less than 200% of the federal poverty line. All these populations had a harder time obtaining contraception. There is also a substantial amount of data that show the demand for or contraception. A national survey of women in the US showed that 62.2% were in favor of over-the-counter contraception. And online surveys of teenagers in particular showed a 73% support rate, and 61% of those people would actually use oral contraceptions if they were available over the counter, which is a pretty big number. A survey of physicians and mid-level reproductive health service providers showed that 74% were in favor of expanding access to pills, patches, and rings, to pharmacy access, but a little less, 47% supported over-the-counter availability. And one of the main concerns, as I kind of alluded to previously, was that they would decrease preventative screenings in patients. Insurance coverage and cost is another barrier to obtaining contraception. This cannot be necessarily solved by pharmacy contraception or telemedicine, but can be solved by over-the-counter options. There is a method for covering over-the-counter contraception within our insurance framework that stems from the Affordable Care Act's contraception mandate, in which the coverage of condoms and spermicide is actually required. So there is a way that we could, in theory, have over-the-counter contraception covered as well. So this brings us to these telemedicine or telehealth models that we have. Because hormonal contraception still requires a prescription, alternatives to in-person methods of obtaining contraception have been invented and gained much traction in the last couple of years in particular. So there are at least 16 online platforms now that patients can use to obtain a prescription. All you have to do is Google how to get contraception online, and you'll get the 9 best online birth control services and many more. As an example of one of these companies, Nurex, this was an online startup that started in 2015. During this time, they initially only offered contraception. This was around the time that President Trump rolled back Obamacare birth control mandate. At the time, 20 million women lived in contraceptive deserts, and this is defined by less than 1 clinic or provider per 1,000 women. Texas at the time was the highest user of this service, or women in Texas, and this at the time was also the state with the highest maternal mortality rate, repeat teen pregnancy rate, and contraceptive deserts. They met some resistance, this company, in a lot of states because they also provided Plan B and Ella at the time. So that obviously conflicts with a lot of state legislation. How do these companies work? Patients go to the website or app, they fill out a questionnaire, and this questionnaire is usually pretty thorough. It includes demographic information, age, state, weight, height, and then also all the medical contraindications and other relevant medical history that would be important that a prescriber would want to know. So including smoking, the brand of birth control, if the patient has a preference that they're requesting, other health conditions, as well as like pregnancy history, breastfeeding history, those kinds of things. Patients are also usually asked to report a most recent blood pressure that they've had taken. The patient then receives follow-up either through direct messages, a phone call, a video visit, happens through a variety of ways. And then if eligible, the prescription is then either mailed to the patient directly to their home or sent to a pharmacy. There was one secret shopper study that looked at 9 of these vendors to really understand how they worked, and more importantly, see if the eligibility and contraindication criteria were being met consistently. So they found in the study that the mean time of interaction with a provider through any means was about 7.5 minutes. 3 of the vendors that they looked at required no interaction at all. Most of the time, these prescriptions were sent to the pharmacy same day or mailed to the patient's home in an average of 7 days. They found that the mean cost for a visit and 1 year of contraception for an uninsured patient was about $313. And also, most importantly, found a 93% adherence rate to the contraindication guidelines, which seems pretty high. Notably, only 2 of the 9 services mentioned LARCs. So counseling on LARCs is kind of a hole in this method. Obviously, they can't provide LARCs virtually, so it makes sense that they're not necessarily talking about them. However, we can all agree that counseling patients on LARCs should be included. So it's also important to know who's using these platforms so we know which populations are benefiting from them. So this study of 38,439 people requesting birth control online prescribing platforms was done. 63% of requests resulted in disposition of contraception. 12% of women in the study who reported blood pressure on the initial questionnaire did have a contraindication to estrogen containing options. 51% of these people were aged 25 to 34. 84.6% requested combined oral contraceptives compared to 6.4% wanting the ring or 4.2% wanting the patch. 5% requested progesterone only. Insurance was billed for 75% of these people. 10% of these people did not have insurance. And in general, 8.9% of everyone that had it was 8.9% of everyone that had a contraindication to combined oral contraception that was not blood pressure. The biggest category was migraine with aura, and that was at about 4.5%. And less than 1% of patients had multiple risk factors for atherosclerosis, or were breastfeeding or had other health history that would be contraindicated. They did a pretty detailed analysis of where patients were coming from by county. They found that more requests came from densely populated urban areas. Requests were highest in areas where Title X clinics, there were only 1 to 2 per 10,000 women. And also the highest requests came from counties with the most uninsured people. When controlling, interestingly, for Title X clinics, the highest requests, the highest uninsured rates actually resulted in the lowest requests. So that's a little bit of a confounding factor. And also the requests were highest in counties where the most people identified as a person of color or were below the poverty line. Interestingly, they found that use was low in people under the age of 18. Even though this platform does address one of the barriers that's cited in this population, which is confidentiality. And it was also less in rural areas, which is surprising, although this could be a technology access issue, because we do know that the proportion of women not using contraception is similar in rural and urban areas. And this is a map really showing the usage of these services by county that the study looked at. Do people like these services is the question, even though they're using them? There was one study that looked at customer reviews from 2 different vendors of telecontraception, Nurex and Planned Parenthood Direct. They concluded that both these services alleviate barriers to access. There were mixed reviews regarding cost and affordability, and that's because of these existing insurance frameworks or the proportion of people who are uninsured using these services. Data was collected from 2017 to 2021, and some kind of key points they found for Nurex, cost was anywhere between $20 to $150. Nurex didn't take Medicaid at the time of this study. So therefore people who had, public insurance actually would have a cheaper cost if they were to go somewhere in person. They also included a 15% consultation fee, and a lot of people cited this as annoying because it wasn't stated up front, all the fees that would go into this. Planned Parenthood Direct was reviewed, and notably their name recognition was an important factor to people. in terms of trustworthiness, and also they're more transparent with their pricing. So these are the things that patients are considering when they're using an online resource. These telehealth companies is an example of some screenshots from a website. So they're very well marketed. They're very easy to use, make it very clear for patients what their options are. So essentially, and how it works. So you request your prescription, doctors review it, deliver your medication, you get automatic refills. So that's really appealing to most people. They'll compare online to in person. They give you, essentially thorough information about all the options on the website, even before you have your potential consultation. And it's as easy as that. So reasonably, people are really using these at higher rates with the COVID pandemic, and probably will continue due to convenience. Moving on to teleabortion. This is another concept that has gained a lot of traction even more recently. This is a concept that's been featured in a lot of mainstream media, including a recent Radiolab podcast, which is quite interesting if anyone wants to listen. So for context, this is a timeline of abortion care milestones. Misoprostol was first approved for treatment of peptic ulcers in the US in 1973. This was followed by the development of Miffy in France. Thereafter, the realization that Miffy plus Meso is actually even more effective at completing medication abortion. So in 1988, this combination was legalized for abortion in France. It wasn't until 2000 that this combination became approved in the US, and this was for gestational ages 7 weeks or under, and required 3 visits essentially, because you would have a first visit for your consult, take the Miffy, come back, take your Meso, come back for a follow-up. And then in 2016, this changed when Meso was approved to be taken at home. So this cut down a visit for people trying to complete a medication abortion. And then also the gestational age was increased up to 10 weeks. Fast forward to the start of the pandemic, the ACLU led a lawsuit against the FDA and proposed that forcing patients to come in for medication abortions poses a greater medical risk. And in 2020, the FDA lifted the in-person Miffy requirement. So that is why patients can now receive all this medication by mail through these services. We know that more than half of abortions are medication abortions, and therefore access to medication abortions should be more equitable. This is one of the silver linings of the COVID-19 pandemic, which is the increase in the use of these services and all the safety data that has come out of it. So the original kind of teleabortion project was started in 2016. This was the first project or study to offer direct-to-patient telemedicine abortions in the US. And their objective was really to evaluate the safety, feasibility, acceptability of direct-to-patient telemedicine service and enable people to obtain abortions without going in person to a provider. It was originally offered in 5 states. Video conference, pre-treatment labs, and ultrasound were required. And if a patient was eligible, then the Miffy, Meso, and detailed instructions were mailed to the patient directly. And in addition to any other supplemental medications like antiemetics or pain medications. And then follow-up labs were also recommended, and a follow-up phone or video visit. Serious adverse events for this study were defined as fatal, life-threatening, resulting in hospitalization, transfusion, or significant disability. The average time from screening to mailing the medication was 7 days, and they found that no participant took Miffy at greater than 71 days gestation. It took place over the course of 32 months. 433 screenings were done during this time, and resulting in 248 packages shipped. They got follow-up data for 88% of these and satisfaction data for 64% of these encounters. The main result is that 94% of patients who received their medication abortion packages aborted completely without the need for a procedure. Completeness of an abortion was evaluated by ultrasound, a decline in a serum HCG or a urine pregnancy test afterwards. They reported only 1% serious adverse events, And these two people, one of them had a seizure after an evacuation procedure, and one of them had significant anemia requiring a transfusion. Both of these adverse events were deemed to be unrelated to the telemedicine form of delivery. In terms of satisfaction data, everyone who completed the survey were satisfied. 77% cited convenience as a major factor, privacy, and communication with the study staff. This study was then expanded and continued through 2020. And during this time was expanded to 10 institutions. And during the entire time frame, 1,390 packages were mailed. They had 83% outcome data, and again, found a very high completion rate of these medication abortions at 95% without the need for a procedure. 6% of patients had unplanned visits after their medication abortions, and they cited 10 adverse events, 5 of which were transfusions. Of note, in the instructions and initial mailings, patients were given a second dose of meso and were instructed in what situations to take that, and only 7% needed to take their second dose. So this study obviously spanned the beginning of the COVID-19 pandemic. And after that started, 52% of patients required no screening ultrasound, and that was deemed to be safe by providers. And additionally, the use of urine pregnancy tests to confirm abortion completion increased from 67% prior to the pandemic to 90% after the start of the pandemic. So here we're seeing a big shift in practice where we're not requiring patients to have an ultrasound to confirm an intrauterine pregnancy, and we are only requiring a home urine pregnancy test to confirm completion of the abortion. And this has kind of led into this concept of a no-test medication abortion, or no-touch medication abortion is another term that is used. These are essentially because they involve no clinic visits at all. So no pre-labs, no ultrasound, and no post-labs or ultrasound. So this is all done online with home pregnancy tests and mailed medications. The main kind of sticking point for this method is really to confirm gestational age in these patients, identify any signs of ectopic pregnancy, and establish that there are no other contraindications. So not everyone is eligible for this method. However, a significant portion of the population is. So with respect to gestational age, the recommendation is that a patient's LMP should put them at less than 77 days on the day of MIFI ingestion. A study in 2005 showed that only 1% of the included patients who were certain that their LMPs had started 77 days prior, only 1% of those people had a gestational age that was actually more than 77 days. So LMPs are actually pretty accurate at determining who is safe to take MIFI. And with respect to ectopic pregnancies, there's a lot of data to show that the incidence of ectopic pregnancy among these patients requesting medication abortions is very low, it's less than 1%. There is also RH status to consider, and the administration of ROGRAM and how we accomplish that. So we know that RH sensitization after early abortion is pretty negligible, and the National Abortion Federation has concluded that not doing RH typing or ROGAM administration is reasonable in RH negative patients who have an abortion before 56 days of gestation, and may be considered for all patients having a medical abortion less than 70 days. So this should not be a reason to withhold a medication abortion to patients. So this is kind of a sample protocol of who is eligible for a no-touch abortion. And we know that this may not be appropriate for everyone, obviously. So as we kind of already determined, a patient has to have a pretty reliable menstrual cycle so they can reliably report an LMP. And as long as this puts them at less than 77 days on the day of MIFI ingestion, they're eligible. There's screening for any kind of ectopic pregnancy symptom like vaginal bleeding, and also risk factors like prior ectopic pregnancy. And then other, obviously, medical and contraindications, such as bleeding disorders. And again, with respect to RH type, RhoGAM is not necessary in patients who are going to be under 70 days gestation, regardless of their RH status. Follow-up for these no-touch abortion patients is typically 1 week, and that can be through a phone call, typically a message, however the platform works. And then completion of the abortion is based on a high sensitivity home pregnancy test, and this should be taken 4 weeks after. There is a 5 to 25% positive rate of these high sensitivity pregnancy tests 1 month after. These are most likely false positives. Therefore, if the patient is asymptomatic upon review with the provider, they're just instructed to take another test 1 week after that. In a 2017 study, they retrospectively compared teleabortions to in-person abortions, and this took place over a 7-year time span and was done at Planned Parenthood of the Heartland. They included 8,765 telemedicine abortions against 10,405 in-person abortions, and they found no significant difference in adverse events. So this is pretty huge when you're counseling patients or, deciding whether these are options for patients or not. There are many, many barriers to obtaining abortions, which might be the biggest understatement of this presentation, but teleabortions do address many of these that are traditionally reported, which are logistical, getting to a clinic in time, social stigma, and also financial barriers. A lot of studies have cited as stigma as a major barrier that teleabortions address, because patients are in the privacy of their home with whomever they want to be supported by, talking to a provider virtually who is in favor of helping them get an abortion and making sure it's safe and easy. And this is kind of in addition to the commonly cited positives of not having to go to a clinic, encounter opposition to abortion at the door, et cetera. So the alleviation, like I said, of many of these barriers informs patients' reviews and experiences with teleabortions based on WHO assertion that person-centeredness should be an element of quality care. This one study sought to evaluate patient attitudes toward teleabortion. So they actually interviewed 45 of the original teleabortion study population. 23 of these patients had a teleabortion pre-pandemic and 22 during the start of or after the start of the pandemic. And the themes that came out of these interviews were that patients felt well supported, safe. They appreciated the autonomy and empowerment they felt. Teleabortion exceeded their expectations. And one kind of negative was that they did experience challenges interfacing with care outside of the teleabortion study. So when they were required to get labs or ultrasounds from local providers, were met with sometimes too many questions or uncomfortable questions, et cetera. These are just some examples of online teleabortion services. So Aid Access is a popular one. And there's a website, as we probably are familiar with, Abortion Finder, especially now, where abortions are even less commonly come by. It's important to note that teleabortions are also only legal or available in states where abortions are legal. So just like for in-person abortions, someone can cross state lines and receive a teleabortion in a state where abortion is legal. So we've gone through all of these learning objectives. The big picture here is that telecontraception has essentially been backed by over a decade of data showing the ability of patients to self-screen for contraindications and provide relevant health information that would allow a healthcare provider to prescribe hormonal contraception without ever seeing a patient in person. Telecontraception also decreases many cited barriers to obtaining contraception, including making doctor's appointments and getting to a pharmacy, among others. And the one barrier that telecontraception does not address is the cost and insurance coverage piece, which is why we need to continue to advocate for over-the-counter contraception in the US. And with respect to teleabortion, it's been shown over and over, the success rates are equivalent, as are the adverse event rates. And the COVID-19 pandemic has essentially afforded us this opportunity to potentially get rid or eliminate of the pre and post testing that used to be important in a world where we were led by convention to have these tests done. And we're now coming to understand that requiring these steps could actually represent barriers to care for some, and barriers that are potentially unnecessary and have consequences. Thank you all for listening. Okay. You can go first, Talia.
Oh, hi, friend. This is a little anecdotal, but I feel like my only exposure to telecontraception is like targeted social media ads, which I'm sure is the way that a lot of patients discover this. But I was just wondering if you know of other ways that patients are potentially gaining access to contraception in this way, or like if it's being recommended by providers in a clinic, or like even if like online from different hospital systems.
Yeah, I don't, as far as I know, there's no public data about providers that work in clinics or hospital settings recommending these services. I think it's something that we should all be aware of, though. And if you see a patient once who may be moving away in a year or in general has inconsistent healthcare, I think it's reasonable to mention these options to patients, say, hey, just in case you're not here and can't get a refill from me and don't have another doctor, like these are options for you that are safe. Especially in the case of they've already seen us, we've already screened them for contraindications, they've already been taking a type of contraception. There's no reason why someone should not be able to get a refill. So, but I think the main method of marketing of these services is through social media and the internet. And like I said, you just Google like, how do I get birth control online? And a list shows up. So, and I think it's helpful that there's a name recognition component to places like Planned Parenthood, because that's a resource people do know about and they do offer these services. So that's, another way people who maybe don't know of these other companies at least could start somewhere. I'll answer the question in the chat. What data are available about trans people's use of these services seems important, since that population is highly likely to have had a bad experience in healthcare settings and to avoid needed care. Yes, I think that's a really important question, and one that I thought about when I was kind of going through a lit review. A lot of these studies that took demographic information of patients when they were getting like qualitative data on experience and stuff like that do not cite sexual orientation or any identifying terms. So I didn't come across any studies that looked at different trans populations in general, but agree. I think we can probably deduce that because patients cited the supportive nature of these platforms and decrease in stigma as such a high draw, I'm sure that this encompasses populations who experience a lot of stigma in healthcare in general. Dr. Landry, yeah.
Rachel, would you clarify again what the legal status is of mailing the abortion medication into the state of Wisconsin?
Yes, I will address that. Dr. Landry was also asking a question and the mic isn't working. So I'll answer hers first and then answer that.
Now it's going to work. There we go. Okay. So in the state of Wisconsin, as well as nationally, the state is addressing through Title X programs the need for access to contraception through telemedicine, and had moved forward. Unfortunately, during the pandemic, a lot of contraception nurses and providers were pulled to do COVID testing and vaccination. But now, as we're going to a new normal, the Title X clinics do see the need and the benefits of telemedicine to address contraceptive barriers. So there are sites opening around Wisconsin that are 100% telemedicine only. locations. So I think in addition to social media, which is absolutely the force behind most learning about new and different ways to gain access to contraception and other medical services, there is, even at the federal level, delivered by states, a push towards developing, sustaining, and innovating telemedicine services. And I will do a huge shout out to Planned Parenthood, who has been the leading force way pre-pandemic. The other is, I believe, in college health, at least for some folks who access care that way. We have been doing telecontraception for, since 2018, and have studied and asked patients why they find it valuable, and to address the non-binary, gender non-conforming, trans population. They, through our patient satisfaction surveys, have identified that this addresses a barrier that makes it, in a more standard in-person visit, not possible for them to step into care. So definitely an area worthy of ongoing study. And again, Rachel, thank you for bringing this to a Grand Rounds audience.
And then the question about the legal status of mailing abortion medication. So essentially, mailing abortion medications, Miffy and Meso, is legal in states where abortion is legal. So these services don't serve the state of Wisconsin, for example, when you go to any of their websites. However, a patient could, from Wisconsin, go to Illinois, have a teleabortion consult and receive their medications there.
I had one interesting thing when I was living in Dubai in 2008, the stock market sort of crashed. At that time, contraception was over the counter in Dubai and the United Arab Emirates, and then their cousins sort of bailed them out. They got taken off the counter. And then you had to have your husband give you a note to get contraception. But it's just kind of interesting that even in the Middle East, it was over the counter. But I have a question with regard to your future profession and specialty. Is there any sort of advocacy opportunity that you might see in terms of the risk reduction with regard to OCPs and making that argument, kind of like the forced birth argument of maternal morbidity, is just trying to say this is equitable preventative medicine?
Yeah, I think you're kind of alluding to the fact that we know OCPs reduce the risk of ovarian cancer with long-term use, among others. And I think that's definitely a piece of counseling that we don't routinely use when we're counseling patients. And I do think about it, but that's also because of my personal interests. And I think it could definitely be used as a tool to help more legislation be passed, or help kind of the risk benefit ratio of these drugs shift to being in favor, or, not as risky as they seem. So I think it's, up to all of us as we counsel patients, especially young patients, to bring those things up as well. Yes, Ala.
Thank you, Rachel, for an excellent Grand Rounds presentation. My question was regarding pharmacy access and whether there's an age cutoff for access to behind the counter contraception, how that impacts access for adolescents and teens, and whether or not confidentiality is protected.
Yeah, that's a good question. And there's no kind of universal answer, because a lot of the pharmacy access depends on state laws, and then also then insurance status of patients and all of those things. So like anywhere, if a patient is using insurance to obtain contraception, and it's their parents' insurance, it's not going to be confidential. And I think the age question, most places are not going to prescribe to patients under 18. However, I didn't come across very good information regarding that. Pharmacy access, I think I was surprised at how many states offer it, because it's not something that you really hear about, even going through the medical education and training system. So I kind of am also interested to know, which I didn't come across in detail, like how many people actually access that method of prescription. Thank you.